Stress fractures. My name is Mary Lloyd Ireland. I'm an orthopedist practicing at the University of Kentucky in Lexington. I'm going to show you some conditions that aren't really what they seem. Stress fractures can be straightforward. There's certain higher risk stress fractures that we should make a point of diagnosing early, such as the tarsal navicular, the dreaded anterior tibial black line, and femoral neck stress fractures. This is a 45-year-old family practitioner who didn't start early enough in training for his 10K race, so he significantly increased his mileage over a 2-week period. He had right groin pain and actually came in to see me with his x-rays and an MRI scan 2 weeks after he started having right groin pain. His plain radiographs really looked normal. Get concerned with groin pain. Does he have something going on with a femoral neck? These films are normal. An MRI scan he brought in really paints the picture of a femoral neck stress fracture with significant bony edema. See it much better on these T2 images. Opposite side is normal, but see the extensive bone edema. This originated on the compression side of the femoral neck, not the tensile side. The tensile side of any bone is a more concerning one for early internal fixation, but this is on the compression side. This is his bone scan. Again, it's about 2.5 weeks since he had symptoms. Increased activity. Inferior aspect of the femoral neck. And this is now 2 months following his injury, and you can really see the sclerosis here. There was never any displacement. He has sclerosis here on this compression side of his femoral neck. He didn't make the race. He stopped running. He used crutches in the office. His symptoms improved very quickly. Follow-up MRI scan because he could order it himself. This is what it looked like. Still significant extensive bone edema. That's 3 months after his injury. And now 3 months on his x-ray, you can still see the sclerosis, almost see a little fracture line right there. And still the MRI scan is abnormal as we would expect it to be. And this is 4 months after his injury. He was ordering his own x-rays. He healed without any problems. So when we look at stress fractures, the ones that will heal are the compression side, as in this family practitioner. Second metatarsal, fibulas will heal. So the compression side of bone will heal. Medial side of the tibia. The low risk, lower extremity. Initial x-rays, sometimes I put a little marker directly over where the complaint is. That helps you hone in on this. So this is a fibular stress fracture. That went ahead and healed. Shin splints or medial tibial stress syndrome can develop into a medial compression side tibial stress fracture. The higher risk are on the tensile side. So if you look at these x-rays, the tensile side, anterior cortex of the tibia, base of the fifth metacarpal or a Jones fracture, and superior aspect of the femoral neck. These are all the tensile side of bone. And it is interesting if you look at the thickness of the cortex in these, certainly the fracture, there's an attempt of the body to heal, but there isn't as great a blood supply, and those tensile forces cause the fracture to not heal. And in these cases, we would fix it with an intramedullary screw. So the critical level of concern that may require surgical intervention, or that dreaded black line of the anterior tibial cortex, medial malleolus, tarsal navicular, proximal fifth metatarsal diaphysis, or a Jones fracture. Early intervention surgically results in a better patient care and outcomes than if there is a displaced fracture. And this is that dreaded black line of the anterior cortex, most commonly in very tall basketball athletes. Another dreaded black line, treated with intramedullary fixation and not really doing anything specifically to the fracture. Ohio State race, Division III girls, about 10 years ago. And if you watch her coming over, she fell down, couldn't put any weight on her left lower extremity, crawls across the finish line. I hope this is not medical staff, because someone goes to pick her up. They pick her directly up. She again tries to put weight on her leg. Wobble, wobble. And then he makes a decision to pick her up. So fortunately he could pick her up, but her leg is still wobbling, unsteady, and without any splint. This is not the way to carry an injured athlete off the court or the course. Probably she had a dreaded black line fracture that was just finished off at the end of this cross-country race. You probably make that a little longer, I guess, or
repeat it.
Yeah, or repeat part of it, maybe when he's picking her up or something.
Alright.
Or you could just leave it as still at the end. I was pretty much on time, wasn't I? Or...
Yeah, you were good. I mean, it was just a little.
So you could just do a still.
Just do it still.
Still at the end, yeah, or something. And I don't. I guess you can't have two. Can you have anything? I don't know. Just probably gonna not use the background of everybody yelling, I guess.
Yeah, the audio.
Yeah.
You heard that.
Right.
In the beginning.
Okay. All right.
I mean,
that's fine. And then cut it off. No.
Sliding, like, cause we'll hear it. And I
Okay.
was like, this is a little loud. I
Right.
didn't realize you would
Yeah.
talk over it. So.
Right. Okay. Yeah, that'll work. Just
But
put
I
something at
turned
the end.
off the audio at this point.
All right. And let's see here. We're about at the end of the stress fracture one. A couple more stress fractures. It's a little creaky around here, doesn't it?
It does. That's a pretty good mic. It doesn't pick up a whole
Yeah,
lot
okay, that's fine.
stuff on it.
I had the privilege and opportunity to be one of the physicians at the Olympics in 1992 in Barcelona. On the night that they had given me off, I went to track and field to see the end of the decathlon. Davy Johnson was our U.S. decathlete who was predicted to win the gold. We had a cardiologist assigned to track because of the obvious problems that they have with their hearts. And before the 9th event of the javelin, the cardiologist had injected his foot. He had a navicular stress fracture that was known to track but not to our medical team. And after he finished the javelin, now going into the 10th and final 100-meter run, he said, I cannot run this and I'm not going to finish unless I'm injected again. So I was found in the stands where I was taking pictures and asked to come down to the tunnel into the medical exam room. And I talked to Davy Johnson. He did indeed want an injection. He hurt over his tarsal navicular. And he said he wasn't going to run unless he was re-injected. He had just been injected an hour prior. I could not talk to that physician, didn't know where he injected him. So I had to make the decision to inject this athlete in the final event of his decathlon. I was a fan from the stands. I did inject him. We knew he had a tarsal navicular stress fracture. He was able to finish the decathlon and got a bronze medal. I was concerned that he wouldn't finish the race, but he wasn't going to run it without an injection. So I did inject him at an Olympic level. Sometimes you do things if it makes sense and is best for the athlete. Typically, I don't inject stress fractures for athletes to compete, but this was an exception to the rule. Did I do the right thing? After all, it is the Olympics. He went on to write a book about his experience in getting the bronze medal, which I think was phenomenal since he was competing with a stress fracture. He talked about the pain in Spain and how much pain he had from the injection, but he stated that the physician was a male, so he didn't remember that I injected him. I was off the hook. Davey Johnson is the athlete on the left, still walking, still standing. Looks like the press and video like the guys that were lying on the track. Quite a feat to be in the Olympics as a decathlete, and quite a feat for him to have gotten the bronze medal. Tarsal-navicular fractures are not that common, but we should diagnose them early. This is an 18-year-old freshman, Division I basketball athlete who had midfoot pain bilaterally, more on her left than her right. She kind of blamed it on the shoes that her university mandated that she wear. When I asked her about her periods, she said she had normal periods. The definition of normal periods for her was having 2 per year when she was not playing basketball, so you must get a little better detail history before you say normal periods. Her pain was all around the navicular, both the dorsal and the plantar aspect. Didn't really have any tenderness over the posterior tibialis tendon. No swelling, no tenderness over her tarsal bones other than the navicular. And this is her original plain film. This rotation film as described by Torg. You can see a fracture line right here. As in the carpal navicular, the blood supply does a turn and then comes back, distal to proximal. She did have a CT scan performed, and the more symptomatic left side, that navicular propagates all the way down to the plantar aspect. A little bit of displacement dorsally, and see how the one on the right is not as significant. This one was treated non-operatively. This one was treated with open reduction internal fixation. However, her bone scan was very hot on both sides. Symptoms had been 2 months of pain. So again, her left, and this was her right, sclerosis there. Body was trying to heal. This 30-degree extra-rotated Torg view is a very good view to see the orientation of the fracture. And this is the typical orientation of a navicular stress fracture. So get this view acutely. If the athlete does have pain around their midfoot, around their navicular, it may change from being plantar or dorsal, but early imaging with an MRI scan, CT scan, or bone scan. You don't need them all. MR would show bony edema. CT scan would show any displacement and propagation of the fracture, as I showed on previous slides. This is a picture of her open reduction internal fixation of her left side. We put her in a wheelchair, her right one healed, and this shows the orientation of the screw, and we did a local bone graft from the distal tibia. She did well. I hope these cases will make you think about certain conditions that you may not have thought about before. Remember, you may not have seen it, but it has seen you.